Today we're pleased to have Dr. Radha Gopalan joining us for a discussion on therapeutic options in pulmonary arterial hypertension and the new European Society of Cardiology guidelines. Dr. Gopalan is an associate professor in the Department of Cardiology at Mount Sinai. He received his medical degree from St. George's University, after which he completed his residency in internal medicine at the Newark Beckersville Medical Center. He subsequently completed his fellowship in cardiovascular disease at Cooper Hospital University Medical Center, and later advanced fellowships in both electrophysiology and heart failure and cardiac transplant at Hahnemann University Hospital. His clinical and research interests include medical therapies and advanced treatment modalities in patients with heart failure, as well as readmission trends and predictors of heart failure patients. Please join me in welcoming Dr. Gopalan.
Good morning, and thank you, Megan. Thank you for being here. I'm excited to talk to you about pulmonary hypertension because it has a very short history, about 22 years of drug development in pulmonary hypertension after a long pause and a hiatus of coming up with new therapies prior to the 90s. Even though the disease was recognized in the 1950s, we did not have robust therapies. So it still remains a orphan disease, especially the pulmonary arterial hypertension. And as such, a tremendous amount of drug developments have happened in the past 15 years at least. So I'm excited to share the current strategies and drug therapies that we have. And we will take a look at some of the European Society of Cardiology recommendations that are now have become more dynamic and changing in nature, as opposed to being a expert consensus statements. Here are my disclosures. And I've divided this into a sort of background because of the mixed audience type. For the training residents as well as the attendings, I had some time to reflect on, to think how I should progress in this talk. So instead of just starting on the drug therapies that are available and then progressing forward, I decided to give a little bit of background to lay the foundation to build on what I'm going to be talking downstream. So in background, we will talk about what is PH very briefly and take a backward look at how we have progressed with regard to drug development and treatment strategies. And then we will move on to the subject matter, and then I'll leave you with some closing remarks and about 10 important take-home points that we can glean from the European Society of Cardiology guidelines that was released in 2015. So let's take a look at what is pulmonary hypertension is, and its definition, and a little bit background on how it's classified, and then how you make the diagnosis. I think that will lay the foundation for us to start tailoring therapy based on this information. So it's a progressive disease caused by narrowing or tightening of the pulmonary arteries. I think every one of you know this. This is just a refresher. And right side of the heart becomes enlarged due to the increased strain of pumping blood through the lungs. An interesting story about right ventricle. It is able to compensate initially very well to increasing pressures in the pulmonary circulation. However, with chronic pressure burden, it starts failing. And then at the end of the disease spectrum, most pulmonary hypertension patients die of right heart failure. And the strain leads to common symptoms of pulmonary arterial hypertension, such as breathlessness, fatigue, weakness, angina, and syncope. And one of the common things that we use is if there is an unexplained dyspnea on exertion, it's prudent to think about pulmonary hypertension in the differential diagnosis. This has become more and more involved as we have been able to recognize pulmonary hypertension even in older patients in the early 2000s to currently for current practice. One of the ways that pulmonary hypertension is diagnosed, and the gold standard still remains a hemodynamic definition. So a right heart catheterization is required to make the definitive diagnosis of pulmonary hypertension. However, right heart catheterization is not required to screen for it, and in current practice, an echocardiogram serves as a screening method, and with the trend in reporting echo results having changed to report more about tricuspid valve and the right ventricular function, we have been able to recognize and identify pulmonary hypertension much more frequently. A standard echocardiographic report now incorporates information on right ventricular systolic pressure, which can be used, and then estimated pulmonary artery systolic pressure will then give an idea about the pressures in the pulmonary system. In the cath lab, however, you have to satisfy at least two characteristics. If you look at the European Society guidelines, they only include mean pulmonary artery pressure requirement of being more than or equal to 25 millimeter mercury, and mean pulmonary capillary wedge pressure being equal to or less than 15 millimeter mercury. If you look at our guidelines in the United States, ACC, AHA, we have incorporated the pulmonary vascular resistance as a required characteristic, although jury is out on the pulmonary vascular resistance as to whether it should be incorporated or not, because the pulmonary vascular resistance, if you know the calculation, it relies on the cardiac output. And as the cardiac output continues to decline with the disease progression in pulmonary hypertension, it begs the question whether one should pay attention to pulmonary vascular resistance downstream. But in our lab here at Mount Sinai, we use the pulmonary vascular resistance, being mindful of the resistance as the disease progresses in a treated patient. So we combine this measurement with the assessment of right ventricular function by echocardiogram to decide whether we should rely on this or not. And then, of course, in the lab, if it is a first time right heart catheterization to confirm pulmonary arterial hypertension, then a vasoreactivity test is still in the guidelines. I know there are several centers and some of the pulmonary hypertension disease management programs have moved away from doing vasoreactivity test, but guidelines still recommends that vasoreactivity testing is required. If not for anything significant, it helps us identify maybe a very small proportion of patients who could benefit from calcium channel blocker treatment long term prior to transitioning to other PH specific therapies. How do you determine someone is vasoreactive? You have to document more than 10 millimeter mercury drop in the mean pulmonary arterial pressure to or below 40 millimeter mercury. So if you dropped it from 55 to 45, it is not positive vasoreactivity testing. On the other hand, if you dropped it from 55 to 39, then it is positive vasoreactivity testing. So for us, this is for the training residents and fellows. When you do, it's good to know the numbers that makes up the definition of pulmonary hypertension, but it is not as clear-cut as it is in the lab. So you will get mixed numbers. So I have put 3 common patterns that one will observe in the catheterization laboratory when you do a right heart cath in patients with known pulmonary hypertension. So you will identify 3 common patterns here. The pulmonary arterial hypertension or pre-capillary without the involvement of post-capillary pressures, or pulmonary venous hypertension or post-capillary hypertension, or mixed of both types. You will have pre and post. How do you differentiate between this in the lab is what is depicted in this table. So this is the requirement we saw. We saw the requirement of having to have the more than 25 millimeter mercury as the mean pressure definition, less than 55 of wedge pressure, and more than 3 Wood units of pulmonary vascular resistance. But if you're dealing with pulmonary venous hypertension, the requirement for the diagnosis of pulmonary venous hypertension with regard to pulmonary arterial mean pressure is still the same. It should be more than 25 millimeter mercury. But what you will find is the pulmonary capillary wedge pressure will be more than 15 millimeter mercury, indicating there is pulmonary venous hypertension. And as a result of the wedge increasing, you might end up having, you will have less than 3 Wood units of pulmonary vascular resistance. On the other hand, if you're dealing with a mixed pattern where you have pulmonary arterial hypertension and pulmonary venous hypertension, then you are going to have similar pattern to pulmonary venous, with the exception of the pulmonary vascular resistance being more than 3 Wood units, because there is some arterial component to it. So the reduction in the gap between pulmonary mean arterial pressure minus wedge pressure is not as big as you will see in the pulmonary venous hypertension. So when you see mixed picture contributing to pulmonary hypertension, then it's up to the operator to figure out whether this is disproportionately high, whether the pulmonary hypertension that is assessed by the right heart catheterization is disproportionately high, or it is consistent with existing left heart failure. Now that in the current era, we decide that by looking at these two parameters. So the TPG, meaning transpulmonary gradient, which is the difference between pulmonary mean arterial pressure minus wedge pressure. So if that is more than 15 millimeter mercury, there is a suggestion that there is precapillary involvement. And then you redefine it a little bit more with looking at what we call DPG, that is diastolic pressure gradient, which is the pulmonary artery diastolic pressure minus the pulmonary capillary wedge pressure. So if that is more than 7 and the TPG is more than 15, then you are looking at precapillary component, even though your wedge pressure may be more than 15. And in that case, then most of the pulmonary hypertension specialists would try to conclude that there is a precapillary component to this, and sometimes we bring the patient back after diuresis, remeasure the pressures, or start treating to do the downstream right heart catheterization in 3 to 6 months. So that gives us a background of how we look at, because this is it has an important bearing in the classification that I'm going to talk about next. So pulmonary hypertension is classified into 5 distinct groups. This is the latest from 2013. So group 1 involves idiopathic pulmonary arterial hypertension, heritable pulmonary artery hypertension, drug induced, used to be weight loss, fen-phen and medications like that, as well as it also happens in some of the illicit drug users, especially cocaine. And it's not the effect of the cocaine, it is what is mixed with the cocaine that is sold on the streets. That chemical nature induces pulmonary hypertension. And then associated pulmonary hypertension with connective tissue diseases, HIV disease, portal hypertension from end-stage liver disease, congenital heart disease, schistosomiasis, and chronic hemolytic anemias. And then, of course, persistent pulmonary hypertension of the newborn. Group 1- is pulmonary venous occlusive disease and pulmonary capillary hemangiomatosis. Group 2 relates to cardiac disease, whether it is related to diastolic dysfunction, systolic dysfunction, mitral stenosis, or chronic mitral regurgitation. So all of these can give rise to pulmonary hypertension, which is classified as group 2. Group 3, as an organ system, it relates to pulmonary diseases. So you can have COPD, interstitial lung disease, sleep disorder, breathing, alveolar hypoventilation disorders, chronic exposure to high altitude, and developmental abnormalities. And then group 4 is a emerging paradigm or emerging group that has seen increasing number of surgical therapies, which is chronic thromboembolic pulmonary hypertension. About 2.8 to 4% of patients who suffer acute pulmonary embolism will go on to develop chronic thromboembolic pulmonary disease by data that is available today. Based on this, our practice here is to monitor those patients who get hospitalized with acute pulmonary embolism with an echocardiographic screening for the right ventricular systolic pressure at 3 and 6 months. And data has shown that if they have not developed pulmonary hypertension by 6 months, the chances of developing pulmonary hypertension is very low, and you don't have to continue to monitor them after 6 months. But it's prudent to monitor acute PE patients at 3-month and 6-month interval before releasing them with the confidence that they are not going to have pulmonary hypertension, unless of course they have recurrent pulmonary embolism. So group 5 is a mixed bag of conditions that give rise to pulmonary hypertension, and everything that is not included in group 1, 2, 3 or 4 is included in group 5. So this is the European Society of Cardiology diagnostic algorithm and how you work up a patient once you have pulmonary hypertension. The ACC/AHA guidelines differs a little bit from this, but I felt this had a better flow and more details, although we won't have time to go through all the details. It will be on the website for you to look at. If you have a patient whose symptoms suggest pulmonary hypertension, you want to work the patient through this. I won't go through this, but essentially the workup will include: 1 is you want to confirm the diagnosis of pulmonary hypertension. 2, you want to eliminate other causes or confirm causes of pulmonary hypertension so that you can classify the patient as to what kind of group they fall into, because that is one of the components in deciding what kind of treatment is going to be tailored to this particular patient. So in that respect, a full diagnostic workup is required. So how have we done in the past few years? And as I said, the very first drug that came up in pulmonary hypertension was in the 90s. Epoprostenol was approved as an intravenous therapy for the treatment of pulmonary hypertension. So between the mid-1990s to 2017, which is about 20 years, we have a tremendous amount of research done on pulmonary hypertension, even though it is an orphan disease. And we have made tremendous progression in identifying pathways as well as medications that tailor and influence those pathways to improve the survival of these patients. And speaking of survival, if you go back and look at how these patients progress, as you can see, as the pulmonary artery mean pressure continues to increase, even though it continues to increase, it will begin declining at some point as the disease progresses. And the reason for that is the right ventricle is unable to generate pressure against the higher pressure requirements. So when the pulmonary artery mean pressure drops with therapy, it is not very comforting to think and decide that the patient is doing well or the disease is getting better. One has to look at other parameters such as right ventricular function to determine if the PA pressure drop can truly be attributed to drug therapy and improvement or retardation of progression of disease, or am I failing? So it could indicate both. And as a result, and that happens because of cardiac output begins to decline with progressive right ventricular dysfunction. So not only the pulmonary artery mean pressure begins to decline, the cardiac output begins to decline, and both in combination results in right ventricular failure symptoms, resulting on right-sided failure and then ultimately death of the patient. So as a result of this cardiac output decline, pulmonary vascular resistance will also start declining. So this is the point where you will start looking at the transpulmonary gradient and diastolic pulmonary gradient to decide if the pulmonary resistance is still high or not. So that's how the disease progresses. And we just looked at the research that has been done, and as a result of these research, I have put together this cartoon that depicts our progress from 1995 to 2015 with the available drug, the armamentarium of drugs that we have, have increased tremendously. In early 2001, we had Tracleer or Bosentan that was released, and we were all very happy to use an oral medication in the early part of the pulmonary hypertension, and that was the only drug for a while from an oral perspective until we started studying the PDE5 inhibitors in the pulmonary hypertension treatment. So as you can see, we have made progress up until the release of Selexipag, which is one of the prostacyclin IP receptor agonists that has been added as an oral prostanoid for the treatment. What this indicates to you is, as you can see here, the drugs that are written in yellow is a stimulator or an agonist in the pathways that we are going to look at. And this theme will progress through my slides so that it gives you a little bit of differentiation in the drugs that you are looking at, and then the drugs that are red, sorry, this is green and red. The red is an inhibitor to the receptors. And then the box indicates the different class pathways that they influence. The purple being prostaglandin analogs that influences the prostaglandin pathway, and the blue being the PDE5 inhibitors that influences the PDE5 pathway, and then the orange being the endothelin receptor antagonist, which influences the endothelin dynamics in the pulmonary vascular system. But overall, the message from this slide is that we have made significant progress with regard to the available armamentarium of medical treatment for pulmonary hypertension, and as a result, we have made some progress in improving survival of these patients. Untreated pulmonary hypertension has an average survival of about 2.8 years, and we have made significant improvement with the oral and intravenous therapies. The contribution of oral therapies is less compared to the contribution by intravenous therapies, although in clinical practice, oral therapies have taken a major role in being introduced earlier and earlier in the state of disease compared to previously about 10 years ago. So let's move on to the subject matter of today, which is the drug therapies in pulmonary arterial hypertension. And most of the talk that I'm going to be talking will relate to pulmonary arterial hypertension, which is group 1, and some information on chronic thromboembolic pulmonary hypertension, and will not address group 2, group 3, and group 5. And I will mention areas where we use drugs to treat those groups, but generally guideline recommendation is group 2 and group 3 are not treated with these drugs that we are going to be discussing. So this is a cartoon of a pulmonary vessel with all the pathways that contributes to the development and progression of pulmonary hypertension depicted within that vessel wall. So if you look at the endothelium and the smooth muscle, the two major components that where all the action happen in the development of progression of pulmonary arterial disease. So the major players, endothelial cells and the smooth muscle cells. And as a result, we talk about vasoconstriction by substances released from endothelial cells, and proliferation of smooth muscle cells with thickening of the wall, resulting in semi or permanent pulmonary hypertension. So as you can see, we have three pathways. These hexagons here are the treatment pathways that I just mentioned. These are PDE5 inhibitor treatment. Then this soluble guanylate cyclase stimulator, which also influences the nitric oxide pathway. And then we have the prostaglandin pathway, and on the right side is the endothelin receptor antagonist. So the prostaglandins and soluble guanylate cyclase are stimulators, and then PDE5 endothelin receptor medications are antagonists. So expanding that a little bit further, as I mentioned, two major players, endothelial cells, smooth muscles, endothelial cells secrete the substances we try to influence, and then and these substances act on the smooth muscle cells to either cause vasoconstriction or proliferation, resulting in progression of pulmonary hypertension. This is the nitric oxide cyclic GMP pathway, endothelin pathway, prostacyclin pathway, and the major player is nitric oxide in nitric oxide pathway, endothelin 1 in endothelin pathway, and prostacyclin in prostacyclin pathway. So we use PDE5 inhibitors to inhibit the conversion from cyclic GMP to GMP, and therefore try to prevent vasoconstriction and smooth muscle cell proliferation. And in similar way with the endothelin pathway, we inhibit endothelin receptor antagonists, and there are selective and non-selective medications available for both, and we try to prevent vasoconstriction and smooth muscle cell proliferation. Prostaglandin analogs are stimulators. They are used in the to influence the prostacyclin pathway to cause vasodilation and prevention of proliferation. So they act on both these two major factors that contribute to pulmonary hypertension: vasodilation and proliferation of smooth muscle cells. So there are other pathways. We have not been successful in bringing out a medication to the market with regard to influencing those pathways, so I will avoid talking about those pathways, rather concentrate on available medications and how to strategize treatment of pulmonary hypertension in the current era. So let's look at the nitric oxide pathway. On the left side is the cartoon I had just showed you. There are 3 medications currently available to influence the nitric oxide pathway: sildenafil or Rebadio, which is you start at 20 milligrams 3 times a day and a target of 80 milligrams 3 times a day in clinical practice. So you can uptitrate as much as tolerated. And then tadalafil, which has a convenience of using once a day because of its long half-life, and you start at 20 milligram once a day and target of 40 milligrams once a day. And then the third drug that was added recently is riociguat or Adempas, which is started 0.3 milligrams TID, target 2.5 milligram TID. It can be increased as tolerated. And riociguat is approved in the United States to be used for pulmonary arterial hypertension group 1 and group 4, chronic thromboembolic pulmonary hypertension, in those patients who cannot undergo surgical pulmonary thromboendarterectomy, or in those patients who have persistent pulmonary hypertension after undergoing thromboendarterectomy. So this drug is used early in patients who are not eligible for surgical therapy, or who refuse or deny or are not inclined to go through the surgery. And this drug is approved for use in group 4. Here is some basic clinical information on these drugs, sildenafil, tadalafil, and riociguat. We looked at the drugs. There are significant drug interactions with sildenafil. One of the most common ones is using it alongside nitrates. So if because of the potential for development of hypotension. So it's discouraged as a concomitant use of nitrates is discouraged in these patients. Tadalafil, similar caution because of the risk of systemic hypotension, and riociguat has the same caution. And one of the other things I want to mention here is that if you're using riociguat, you couldn't use sildenafil or tadalafil. So it excludes it for the same reason. There is a significant potential for hypertension and related morbidity. Absolute contraindications are listed here. And then some of the few things we keep in mind looking at patients who are on these medications to see if they are developing these ocular problems, severe hepatic failure, and pregnancy is also highly discouraged in patients with pulmonary hypertension. If a patient has pulmonary hypertension, you advise that they use at least 2 methods of contraception if they are not using a permanent method. And most of the time, with regard to any of the pulmonary hypertension medications, what prevents us from optimizing therapy is development of side effects. And the most common side effects are mentioned in the next few slides. Headaches, flushing, and nasal congestion are the more common side effects of the PDE5 inhibitors. So patients are asked at every visit whether they are having these problems and during optimization. Looking at endothelin pathway, you have again 3 drugs, bosentan, ambrisentan, and macitentan. Bosentan, released in 2001, was the first one that starts at 65.5 milligram twice a day to the target of 125 milligram twice a day. And ambrisentan starts at 5 and then optimized to 10 milligram once a day before you start thinking about combining therapy. Macitentan is a once a day bosentan type medication. Is 10 milligram once a day drug. One of the difference between bosentan and macitentan is that it's once a day, and second, with bosentan you have to evaluate hepatic function on a monthly basis. With ambrisentan you don't, and with macitentan it is recommended you don't have to. Although FDA has mandated a registry be formulated, and we are currently running the registry in this hospital and across the nation on macitentan use of patients to capture chronic liver function abnormalities that may come to play with long-term use. Similar information on the endothelin receptor antagonist. Again, lots of interactions with bosentan. Some of the common medications that are used, antifungals with ambrisentan, and no relevant interaction with macitentan. That's one of the attractants of this drug. So one of the 3 attractive points about macitentan is once a day, doesn't appear to have hepatic adverse influence as bosentan does, and doesn't have a lot of interactions. And then absolute contraindications are similar, with bosentan having cyclosporin co-administration as a absolute contraindication and severe liver disease. Again, common side effects: headaches, nasal congestion, flushing, nausea, hypertension, palpitation, anemia, and teratogenicity. So pregnancy is highly discouraged, and the drugs are not dispensed through a normal pharmacy. Patients have to go through what is called a REMS program to obtain it, where pregnancies are monitored. Prostacyclin pathway, we have again 3 medications: epoprostenol, treprostinol, and Celexipac, as well as Eloprest. There are 4 of them. The epoprostenol, treprostinol, and Eloprest are prostacyclin analogs, and Celexipac is a non-prostacyclin but prostacyclin receptor agonist, functions like prostacyclin. And that is a new release, a new addition in the prostacyclin pathway. This is an oral prostacyclin influencer. And there is one other drug, treprostinil, also comes in oral preparation. The trials have been disappointing, so I have not included it, and we in our practice here don't use it as much as the drug makers would like us to use it, but there is no robust research data to support use, especially when you have other medications. Similar information on this. This is a busy slide. I won't dwell on it a lot, but one of the key differences will be addressed here. So epoprostenol and treprostinil intravenous formulation. In the United States, Eloprest is approved only as an inhaled. The IV formulation is approved in New Zealand, and Celexipac is the oral IP receptor agonist that became available recently, which is an oral preparation. So in patients where you are thinking of adding a prostacyclin analog to existing medications, if they don't like going on intravenous or subcutaneous modulations, then you could start with Celexipac. With available drugs, the strategy of treating pulmonary hypertension has become complicated, and it involves a lot of thinking process to decide how to treat and add medications. So the intravenous formulations and the subcutaneous formulation with regard to treprostinil is administered in nanograms per kilogram per minute, and then selexipag is microgram. An up titration schedule is given here. Significant drug interactions are given here. One of the things with prostacyclin analogs is to look out for platelet function and platelet counts. It has inhibitory effect on the platelet function. So if someone has low platelets, you want to be cautious in initiating and want to go slow on up titration while monitoring platelet function. Currently we have one patient whose platelet is about 60 to 70, has been on treprostinil and being up titrated very, very slowly. So the question comes, we know with regard to pulmonary different groups, there are certain groups we don't, specific drug therapy is not recommended. So group 2 and 3 at this point has no recommendations with regard to specific drug therapy with these medications. Group 1 and 4 has recommendations and have medications available. Majority of the drugs are used in group 1, and CTEF has riociguat as an approved medication. So no therapy with regard to those groups where we don't have any recommendation, and then the question becomes, do you treat with 1 medications, 2 medications, 3 medications, or when do you add medications? And do you add it right at the beginning, go early, improve survival, or you add at the last minute when they are declining in function? This reminds me of pulmonary hypertension at this point is an era that reflects, that looks like an era in heart failure, advanced heart failure that we went through in the 90s to early 2000s. We have proliferation of heart failure medications were discovered and administered and have had tremendous impact on the survival of these patients. Currently, pulmonary hypertension is going through a similar phase. Lung transplant remains the ultimate treatment for severe pulmonary hypertension. And atrial septostomy, we won't talk about it, it still functions as a bridge to transplantation in patients who are failing medical therapy. So if you want to look at the progression from screening to diagnosis with right heart cath, initiation of medical therapy, close follow-up in a disease management program, and then failing patients go through atrial septostomy and then get connected with transplant program to undergo lung transplantation, which doesn't have as good survival as other organ transplant, but it's still better than if they don't have transplant and have to live with pulmonary hypertension. So what are the recommendations? Here are the recommendations, and the recommendations are divided into based on functional class. So functional class still remains a good predictor of mortality and morbidity in these patients. So we look at class 2, 3, and 4. As you can see, the reds are inhibitors, greens are stimulators. You have all of them in group 2. All these medications are recommended to be used. Ambrisentan, bosentan, macitentan, riociguat, sildenafil, tadalafil. Now, all these medications are recommended as first-line therapy for pulmonary arterial hypertension. And then if you go to class 3, those medications that are recommended for class 2 as well as the prostacyclins are recommended to be used. And then in class 4, only epoprostenol at this time is recommended to be used by guidelines, although most of the pulmonary hypertension centers will use treprostinil as well for the advantages that I will discuss that what treprostinil has. What treprostinil does not have is the data back. Is that the epoprostenol study was an event-driven study, and treprostinil IV does not have data. Treprostinil subcutaneous formulation has data. Subsequently, the company did an analysis with regard to bioavailability of the treprostinil through IV and confirmed that the bioavailability between IV and subcutaneous administration is the same, and therefore the clinicians are comfortable using intravenous medication with regard to treprostinil. And then in class 4, you could consider use of ambrisentan, bosentan, or any of those drugs that we use in class 3, including the inhaled prostacyclins. With regard to inhaled prostacyclins, you have elaprost and treprostinil, which is called Tyvaso. So those are the names that comes up when a patient gets admitted in the hospital. Just a brief introduction of what they mean to you. There is another medicine called Beraprost that is not approved in the United States, but approved in Japan and South Korea for use in pulmonary hypertension. This is an oral preparation, which currently we are studying in this institution in combination with Tyvaso in a study called BEAT study to see if we can use it alongside inhaled Tyvaso or inhaled treprostinil to bridge the gap between the inhalations to maintain steady state of the drug. So those are the drugs. That's the progress we have made. Now, how does one decide how to initiate therapy, and then how to combine therapy, when to change therapy, and when to add therapy, and when to refer the patient to transplant? So these decisions these questions are asked at every time patient comes for follow-up, and then you want to keep a very close eye on these patients. Because the data currently suggests that about 40% of the patients at the time of death are only on monotherapy. That is not acceptable in an era where we have a lot of medication that can be used. So 40% of the patients are dying on monotherapy with pulmonary hypertension. That reflects how much how much work we still have to do in influences. But one of the things I want to add here is risk assessment in PH. I get asked all the time, when do you start treatment? How do you up titrate, and what do you do? All the patients, when they come for the clinic visits, will have at least every visit they will have NYHA classification determination and assessment with regard to progression, improvement, or stability, and will have a 6-minute walk, which is a very simple test as a surrogate to evaluate functional capacity on these patients. We don't rely on cardiopulmonary exercise test at every visit or even periodically, but some of them may have had cardiopulmonary exercise testing at some point at the beginning of their disease process. It is hard in some patients to do cardiopulmonary exercise testing because of institution of chronic oxygen use in some of these patients, and you don't have a way to do a cardiopulmonary exercise testing while having the oxygen continuously delivered to you. So based on this 6-minute walk test, you will see has been one of the predominant player in pulmonary hypertension world and continues to be a player. All the trials that I have shown to you in the 90s and early 2000s and even late 2000s have relied on improvement in 6-minute walk test as a primary endpoint. And now we are beginning to move towards event-driven trials. So that's progress. But most of the drugs we use have only shown improvement in functional capacity, and then we extend that as a surrogate to reflect that functional capacity improvement in functional capacity will improve survival. That was based on the study where 6-minute walk distance of 330 meters or above is associated with improved survival, as opposed to 6-minute walk distance less than 330 meters. So since that time, we have used 6-minute walk. So these parameters needs to be looked at in these patients with close follow-up. And I have put these parameters here to decide, is a patient at low risk, intermediate risk, or high risk? That's the question a clinician will ask with regard to pulmonary hypertension. It used to be low risk and high risk. The 2015 European Society of Cardiology, with the research that we have now devised a 3-tier risk assessment program where you have low risk, intermediate risk, and high risk. So as an overall measure, if someone falls into the low risk category, we start with monotherapy in these patients. Okay. If someone falls into the intermediate category or shows evidence of progression from low risk to intermediate risk, you think in terms of 2 medications. And then when one thinks in terms of 2 medications, you are thinking, do they have to be sequentially added to one? In other words, do you start monotherapy and then add a medicine, or do you start upfront dual combination therapy? And then when it comes to high-risk patients, my practice here, and the practice differs across the centers, my practice is to go aggressive and walk back. In other words, we go with intravenous administration of treprostinil therapy to begin with, and then start adding the oral therapies as the patient is stabilized and follows up in the clinic. There are centers where they will use oral therapy first and then use intravenous, but by the time a patient is class 4 at the time of diagnosis, you are looking at pretty poor outcome, and they should be concomitantly related to a transplant center if a PH program is in a non-transplant center. So this helps us decide how to start treating patients. And based on this, and I just alluded to the fact that we are now thinking in terms of combination therapies and do not leave patients on monotherapy, this cartoon depicts the trials that have looked at sequential combination therapies. And the red lines connecting those hexagons indicates trials that failed or did not show benefit of combination therapy, and those trials are listed below. And the hexagon, the green lines connecting the hexagon, those trials reflect trials that showed beneficial effect on sequential therapy. So just thinking of combination therapy is not enough. At this point, there are trials that shows no benefit to certain combinations and benefit to other combinations. So one has to be familiar with the trials that have shown benefit and choose the drugs, combinations that have shown benefit in trial, at least in limited available trial data, to decide the combinations. So for example, if you look to combine PDE5 inhibitors with endothelin receptor antagonists in here. So for example, if you have a patient in intermediate risk, you want to add 2 medications, and we are talking here about sequential combination. So you want to start with PDE5 inhibitors, or you want to start with endothelin receptor antagonists, and you want to add another medicine. You want to look for the trials that are mentioned here to choose the drugs, because Ambition trial looked at ambrisentan versus ambrisentan or tadalafil alone. This was an upfront combination trial, we will talk about it a little bit later. And Seraphin trial added macitentan to other medications in a sequential fashion and showed benefit. And Seraphin trial is also an event-driven trial, so it's a little bit more robust trial than the other trials we rely on. So that's kind of the strategy one wants to use when one is thinking about combining treatment for pulmonary hypertension. So with development of drugs, the complexity of making decisions with regard to treating these patients have also become more complex. But on the positive side is their survival have improved, and they are postponing transplant requirement more successfully. So what is the guideline recommendation and what level of recommendations are available for this? And obviously greens are level 1 recommendation. As you can see, again, recommendations are divided into class 2, 3, and 4. So ambrisentan, bosentan, macitentan, sildenafil, and vardenafil is not approved in this country, tadalafil and riociguat. Now you are familiar with these drugs. They are all class 1 recommendation for functional class 2 and class 1 recommendation for functional class 3. So that's easy to remember. All these medications are class 1 recommendations for functional class 2 and 3, and then 2B for class 4. When it comes to prostacyclin analogs, intravenous epoprostenol is recommended for class 3 and 4. Inhaled elaprost is recommended as class 1 for class 3, functional class 3. And with regard to treprostinil, subcutaneous and inhaled are recommended as class 1. Intravenous is still class 2, and this is 2015 guidelines. So with regard to prostacyclin, there are slight differences in the recommendations. And then the oral IP receptor agonist that was released in 2015 is recommended as class 1 recommendation for functional class 1 and 2 patients. So as I mentioned before, the expert opinion is continuously evolving, and we have now moved from monotherapy especially also based on the fact that, as I mentioned, 40% of patients die on monotherapy. And the trials, at least some of the trials and some meta-analyses have shown improvement of combination therapy, either mostly sequential. The expert opinion has changed. Now the current recommendation is in case of inadequate clinical response, sequential combination therapy is recommended, is evidence level 1A. In functional class 3 or 4 patients, initial combination therapy may be considered, evidence level 2B, consensus opinion. So we have changed. So reflecting that is the recommendation here for sequential combination, and that has the drugs listed here. So if you, one of the things we do is we keep this in our clinic practice as a little printout, so it's easier to look at when you want to do sequential combination, which is guideline based. And then if you want to deviate from it, you have to at least have a baseline to deviate from, and not just going without a direction based on the trials. Recognizing the fact that pulmonary hypertension trials have historically included small number of patients because of the fact that it is an orphan disease. So we don't have a lot of, although there are more than 5,000 patients studied to date on all the trials, but individual trials have not included. I think one of the biggest trial is the Selexipac, which included about 1,156 patients in them. So, so combination therapy details are there. And then, as I mentioned, we are in the era of evolving paradigm, looking at combination therapy and going on to event-driven upfront combination, which is what we have now. Ambition trial looked at ambrisentan versus tadalafil or ambrisentan alone, which is an event-driven trial. Primary objective is time to clinical failure, not 6-minute walk distance. 6-minute walk distance was a secondary objective. And this is the trial design. And here is the how they defined the events. And as we go forward, it is a very significant trial, p-value of 0.002, suggesting upfront combination benefits with regard to events. Although one should note that most of the events, all events contributed to reducing time to clinical failure was driven by a reduction in hospitalizations. Okay, it's a very soft target there, but it is still a positive trial. So based on this, upfront combination therapy is now recommended in the guidelines. So they do recommend, based on this positive trial, ambrisentan tadalafil should be considered as upfront combination therapy in patients who fall into this intermediate risk category. So what to look forward to? In closing, I would like to say there is robust evidence supporting a strategy of sequential combination therapy in PAH. Not all combinations appear to be associated with similar benefit. It is unclear whether differences are due to the design of the RCTs, differences in populations, or interaction between compound or true efficacy issues. If timing of sequential combination remains to be better understood, initial combination may be considered as standard of care based on the Ambition trial. The jury is out to decide whether we should move from a drug-oriented to a strategy-based treatment algorithm. So there is thinking pattern change that influencing all 3 pathways may be more beneficial than sequentially influencing single pathways. Increase in survival related to research is something to look forward to, and genetics. In this institution, we have just started a genetic study on PAH patients to see if we can modify influence of genetics on development of pulmonary hypertension. And then I want to leave you with these 10 take-home points, which is, we have covered this in the talk. With regard to diagnosis, right heart catheterization is recommended. Vasoreactivity testing is still at play with regard to deciding treatment. When it comes to risk stratification, it is recommended to evaluate the severity of PAH patients with the panel of data derived from clinical assessment and exercise test. That is the risk stratification slide that I put in there. And it is recommended to avoid pregnancy. Disease management program is strongly recommended, and this involves not just cardiologists and pulmonologists. It suggests cardiologists, pulmonologists, as well as other physicians who take care of pulmonary hypertension, nurse specialists, research coordinators, and every ingredient that is required for a successful disease management program, as well as other subspecialists such as rheumatologists, infectious disease professionals, and catheterization lab and things. All those other people who help maintain and conduct a successful disease management program. When it comes to drug therapy, I think we have covered all the other 4 points that is mentioned in drug therapy. And surgical therapy, I mentioned briefly, pulmonary endarterectomy in deep hypothermia is recommended. We have performed about 11 successful pulmonary thromboendarterectomies here in this institution. Dr. Reddy has performed those surgeries, and we are building a CTEF program currently. With regard to our program, in addition, we have about 7 trials that are 5 ongoing and 2 more to come, and one of them is exciting in group 2 pulmonary hypertension, study of oral treprostinil to assess efficacy. And with regard to disease management, Dr. Dua and Dr. Pua work with me in the pulmonary hypertension program. We have the ingredients such as a dedicated nurse practitioner, research coordinators, to have a successful program. I will leave you with these thoughts. Thank you very much.
I was a little late, but we could take a couple of questions, yes.
Yeah, thank you very much. As we all know, most cardiovascular diseases occur more often in older people than middle-aged people. But that isn't true of this disease. It seems to me it occurs quite frequently in young and middle-aged people and not so much in the old. If that's correct, what's your take on all this as far as the impact of age and this entity you're talking about?
The impact that paradigm is changing slightly. So in the past, it used to be young people. It still remains young people with female predominance to males with regard to pulmonary arterial hypertension. However, when you think of pulmonary hypertension as a global problem, we are recognizing more and more older people. In fact, I have 3 patients who are more than 90 years old in my practice who are not on any robust therapies but are using monotherapy. And because of the echocardiography, the widespread use of echocardiography and screening method, the older people are being identified as having pulmonary hypertension.
Okay, I think any other questions can come up front. Thank you very much.